pioneer in the area of global health research on sickle cell disease. So without much ado, Dr. Webb.
So I'm going to talk about hydroxyurea around the world, but maybe I'm going to just begin with a little bit of background and then move into what I think might be more interesting for this group. Recognizing that we are almost on the brink of having curative therapy, although I'm putting curative in quotations, and I'll mention that later. It's important that we spend time thinking about how to take care of the patients who are already here, who are not eligible, suitable, or ready to have any kind of curative intervention. So if you are looking at the pathophysiology of sickling and wondering how it happens from the individual red blood cell down to the patient who's sick all of the time, there's a series of events that are semi-sequential. They are almost in a cascade, although once it begins, it's more like a mudslide as it goes from sickling with inside the red blood cell to the patient with widespread end organ damage. And if you were trying to think where would be a good way to treat, and this session will highlight areas all along this continuum where new interventions are available to interrupt this process as we go from sickling to red cell changes, tissue changes, organ damage, body changes. But I'm going to speak about hemoglobin S polymerization. If you can inhibit this, this will maybe have the greatest impact at the highest point in this cascade. And I think it's important to hear this clearly, that even though we have interventions that are more downstream, and we think of sickle cell disease as an adhesive problem or a hemolytic problem, it's fundamentally a sickling problem, and sickling is the sine qua non of this disorder. There are other hemolytic diseases, more hemolytic in fact, that don't have any of these phenotypes. So I'm arguing that we should go right up front and try to inhibit the polymerization. Now, if that's where to treat in the cascade, then how best to treat? Well, we know that hemoglobin S We know this from natural history studies that were done in Jamaica here with Professor Sargent, as well as in the US cooperative study, that fetal hemoglobin is really an important predictor of both morbidity and early mortality in sickle cell anemia. And in addition, we have the, quote, experiment of nature, end quote, that shows us if we have the rare genetic deletion called hereditary persistence of fetal hemoglobin with pancellular distribution, the cure, if you could hit 30% in all the cells. So it's probably known to you that hydroxyurea has been around a long time. Who knew that it was the 150th birthday of hydroxyurea, synthesized in 1869? Trials trying to identify active agents. Lots of drugs were coming off the shelf, being put into cellular models, animal models, and in fact, hydroxyurea had a potent anti-leukemic effect. And in addition to that, then, it has been tested and found to have potent anti-HIV effect. It was in protocols in the 80s and 90s for anti-HIV therapy. Sickle cell is its third invention, that it can induce fetal hemoglobin. And I won't go into a lot of the history of how it was identified, but my point is to say that even though it carries this chemotherapy label, you really shouldn't think of it as that any more than you would prednisone is an anti-leukemic drug. Glycolytes and white cells, so it makes cells less sticky. It gives you a better blood flow, which we call rheology. It has a nitric oxide component to the molecule itself, for those of you that worship at the nitric oxide altar. And so it has many effects there. And it even has direct effects on the endothelium that give benefit to the treated patient. On the right, you can see the before and after. This is not the worst case to the best case. This is an average peripheral blood smear showing the changes that go from untreated to treated. The cells are more numerous, so there's less anemia. The cells are larger, they're rounder, they have more hemoglobin within them. But it's not a cure. There's still some cells that are over 35 years of research. The first published article that I'm aware of was in 1984 from Oroplat, showing a response in 2 adult patients in induction of fetal hemoglobin in reticulocytes. We now have 35 years of trials. I'm not trying to get you to read the individual trials, but I have highlighted in green ones that were called phase 1-2 trials, and in red, phase 3 trials. So we have data all along the continuum from infants to adults to different disease states, and we're still coming up. And if you're ever lying awake at night needing something to help you go to sleep, the NHLBI has published guidelines, 300 or 400 pages of marvelously written data about how hydroxyurea works and how it can be used, and Chapter 5 is on hydroxyurea. And it has recommendations both for adults and children. Here it is for adults. Educate all patients, that is, they should hear about the disease. Consult a specialist, very relevant in light of Dr. Hassel's wonderful talk this morning showing how many patients in the U.S. do not actually come to specialist care. For children, we also educate, offer. The word was chosen by the panel not to be so definitive to say you must treat, but to offer, to have a discussion, to explain with families and what we call shared decision. Clinical severity. This is a bit debatable. Should you treat somebody before they're very sick? Well, I think that depends on philosophically whether you think a patient is doing well and not needing therapy if they're not in pain or not in your emergency room. If you realize that they're having sickling all the time and that they're slowly damaging their organs, you might say that they need treatment even if they're not appearing to be sick. Good control. All right, but I'm supposed to be talking about using hydroxyurea in lower resource settings, and I don't think this projects too well. It looks a little bleached out, but as a map of the world, low resource. To have explained all this to us. But if it's bad now, it's only going to get worse. We have a projected 30% increase in the next generation, and so we really need to do something about the patients who are being born every year. So the World Health Organization has given us some advice. It has a publication from 2010 that said, here's the way you might want to approach it. This was specifically for Africa, but probably relevant for all low resource settings. It has things that are important for just defining the burden of the disease in these countries, such as surveillance and national strategic plans, but it also has principles and priorities that relate to hydroxyurea, from partnership, capacity building, affordable medications, and research promotion. And at our place, we've really tried to focus on these principles, particularly the research promotion and capacity building and partnership. There's lists of what are called essential medicines, and hydroxyurea, or hydroxycarbamide as it's called on this list, has been on the adult list as well, but this was the first time in 2011 that it made the list for children. And it's listed there not just for treatment of leukemia, but specifically for medicines for hemoglobinopathies. So as I think about hydroxyurea, what do we worry about in the United States? What do our co-investigators in Europe in the higher resource settings, what do we worry about with hydroxyurea? Well, we think about when should we start it? Should we wait till the family asks? Should we wait till we're ready? Do we have a set period of time? Do we escalate the dose? Do we just use a low dose? Do we use a higher dose? That's a whole nother discussion. In the US, we tend to escalate. In Europe, not so much. Problems or different questions. You're wondering about the safety and feasibility. Can I even get the drug to the patients? Will they come for the drug? Do I use a fixed, easy dose? Things that we deal with routinely in the US. And so this is a new area that needs to be explored. Education and training I list here not just for patients and families, but for providers. Who's going to administer the drug? Who's trained to do this? Should it be incorporated into primary care groups, or should it be the domain of specialists in low resource settings? And who would those specialists be? And then the really important pharmacoeconomic ones of drug availability, more widely. Here are formulations. I'm going to try to be careful not to name names, but here's the price. I went online. You can order anything online, as you know, and yesterday I acted like I was ordering hydroxyurea and got generic capsules for 78 cents a capsule. Hundreds, 300s, and 400s, and those are a little more expensive even though they have less drug in them because it's a different formulation. There's a tablet available, and wow, that price went up. $5 for 100 milligrams and $52 for 1,000 milligrams. This is US prices, not of the problem with trying to give it to infants and toddlers if you don't have a liquid formulation. And there is one company that has it approved for use, at least it's EMA approved, not yet FDA approved for liquid, and I'm looking at it. All right, so on to this idea of global health research. You know, clinicaltrials.gov lists all the treatments and research trials around the world at any time, and there's now over 300,000 research trials that have been done in over 200 countries. Well, if you filter that down and say how many are dealing with sickle cell and hydroxyurea and are open, meaning not done 5 years ago or 10 years ago, there's 50. In India. But just as a central global clearinghouse, research is really sparse, and I think we need to do better to partner from West and East. So I'll give you just a couple of quick examples here. Here in Jamaica, we have partnered with a fantastic team that is doing work ASH in 2 months. We also have a good partnership similarly in Dominican Republic, where the prevalence of elevated TCD seems to be even higher. This is Dr. Luisana Sanchez, who learned TCD and is by the ASH Global Scholar Award. And so these are I want to highlight 2 quick trials. No Harm is one that was done in conjunction with Chandy John from Indiana and Bob Opoka from Uganda. This was supported in 2017 as a phase 3 double-blinded placebo-controlled trial. It was the concern wasn't that it wouldn't work for sickle cell, the concern was what would happen to malaria. And in TCD. We have this large cohort of patients, almost 200, and now they're in a trial called the MTD Trial. This is the first effort to really get to the question of, does dose matter? So we have half the patients at a fixed dose of about 20 and half the patients at an escalated dose approaching 30. And we'll see whether that makes a difference. Will one be more toxic? Will one be more beneficial? This will be an ASH oral presentation in 2 months. And we hope that Dr. Opoka from Uganda will give this talk. The REACH trial is one that I'm really proud of as well. This is a sub-Saharan Africa, 4 countries. You can see the investigators listed there. Is Fenella able to see that picture? I want you to document that Tom Williams' publicist has personally approved his picture. He never likes the pictures I show, so I'm trying to show. This is Brigida Santos, Leon Shalolo, and Peter Olupat. This is a big trial. It was presented at ASH last year. 600 patients treated and over a wide range of ages between 1 and 10. It had great effects not only on the sickle cell events, but also on malaria transfusions and death rates. And this is Leon presenting on the day of his ASH plenary talk. And thanks to Julie Makani for taking that picture. I don't know if you remember it or not. And then the New England Journal paper that Leon is first author on. So really good evidence that you can do great work and learn a lot while we're doing prospective research and building capacity in each of these countries. So I want to end with 3 ideas about hydroxyurea. Have we done everything we can? Is this just an old drug that has no new tricks? Well, one is the question, can we really think of it as achieving curative effects? And I put curative in quotes because the people who do transplant and gene therapy talk about 30% fetal hemoglobin as being curative, even though we really think it should be called ameliorative. But in fact, if you start early, and if you use high dose, you can achieve this very well. Use it early, use it often. And we're now starting between 6 and 12 months, and we're seeing graphs like this. This is a little boy that I saw last week. He's 5 years old now with his hemoglobin F of 50% that he's had for the entire 4.5 years that he's been treated. And his F cells, as Dr. Quinn will present at ASH in 2 months, is about 90% or more. So he's achieving pretty close to what we would call curative levels. And how do we do that? Well, we should be better about dosing. We don't have to say one dose fits all. And my colleague Pat McGann with our pharmacology group says that every patient should be its own teacher. And we can give one test dose. We can measure hydroxyurea pharmacokinetics using 3 simple blood pricks of the finger. One 15 minutes after they take it to see how quickly they absorb it, an hour later to see how they distribute it, and 3 hours later to see how they excrete it. And based on that, you can calculate their area under the curve, and cha-ching, you will have a dose of 29 milligrams per kilogram. And this has been tested in our single institution, 50 patients, reported a few months ago, and is now in a multi-center trial supported by Doris Duke. And the last idea about hydroxyurea is it safe when women are pregnant? And this is a call to all these international sites and all these investigators that are using hydroxyurea in women who are either of childbearing years, who have become pregnant, who want to breastfeed their babies, and want to know, is it safe? We have now an IRB-approved protocol that allows information to come up about exposures during pregnancy or during gestation or lactation to try to get an answer of this. We think there's a lot more use than has been recognized, and we hope that this will be something that we can build on. So I'm out of time, but I want to acknowledge all the teams around the world that have helped, and I'm happy to answer any questions. Thank you.
Thank you, Dr. Russell Ware. That was magnificent. I'm not going to say anything else, and we'll take questions only at the end of the session. So I will quickly invite Dr. Matthew Heaney from Boston Children's Hospital to talk to us about an update on clinical trials in sickle cell disease.
Thank you, Ren. So first we'll briefly talk about the pathophysiology only because I want to talk about pathophysiologic approaches. I know all of you are aware of the pathophysiology, but I hope not to burden you with that before we move into the therapies. And so as you all know, here this cartoon showing the hemoglobin molecule here as it relaxes and exposes its hydrophobic valine substituted amino acid. In this cartoon now these hemoglobins represented as circles. And as they are deoxygenated for a longer period of time, it allows them to polymerize. These hydrophobic amino acids non-covalently bind to each other. And this reaction is pushed forward to the right by lowering pH or increased acid, by lowering oxygenation, by lowering temperature. And eventually what happens is you get a nidus of this hemoglobin polymer that then grows very rapidly to make a big, long, as I tell the kids in clinic, Lego stick of hemoglobin, which then leads to all of the damage. And so in this cartoon, you can see again, here is your alpha-2, beta-2 heterotetramer, and the beta globin is mutated in sickle cell disease when it's deoxygenated. And our cartoon here shows an indent and outcropping, really like a Lego for the kids in clinic. And they snap together, and so instead of free-floating hemoglobin S molecules, you get these big, long polymers which change the sickle-shaped cell, the normal biconcave disc into the sickle-shaped cell as these polymers all line up. And you sort of get this ugly sickle Japanese throwing star type cell that you see here, which causes many of the problems. Another important concept is that of the delay time. This is the period of time for which when the hemoglobin is deoxygenated, but not yet polymerized. And so here in this cartoon, you can see the biconcave disc has been cut in half. You can appreciate the little dots represent the hemoglobin S molecules. And as you reduce oxygen and allow that time to pass, you can see the polymers will begin to form, and then ultimately, if it's deoxygenated for enough time, that you'll distort the shape of the cell into the so-called sickle shape. And this is important because it explains some of the pathophysiology where in vascular beds which have very rapid blood flow, like the coronary artery, are almost never occluded, whereas vascular beds such as the spleen, which has a very disorganized blood flow, non-vascular blood flow, gets targeted quite early in the disease. So polymerization leads to distortion of cell shape. I hope I've shown you. Ultimately, the red cell membrane becomes damaged. This results in the hemoglobin S concentration in the cell going up as water is lost from the cell, and that promotes the polymerization reaction forward as well. This ultimately results in a irreversibly sickled cell. The membrane can't go back to its normal conformation. And the two main pathognomonic findings of sickle cell, of course, are this premature hemolysis, the shortened red cell lifespan that leads to sort of classic hemolytic anemia findings, and then at least simply the rheologic changes of that red cell, which is in its sickle form, leading to impaired blood flow and downstream tissue infarction and dysfunction, and ultimately maybe even tissue and death. Another part of the pathophysiology here would be related to hemolysis. Here, I'm not a very good artist when it comes to PowerPoint, but looks like this red cell's vomiting. But it's actually hemolyzing. And of course, with hemolysis, there's free hemoglobin put into the plasma, and this hemoglobin consumes an entity called nitric oxide, which used to be called endothelial-derived relaxation factor, which is produced by the endothelium and allows the smooth muscle of the blood vessel to relax to allow vasodilatation. And so if it gets consumed, the blood vessel can get quite twitchy and can even cause some vasospasm potentially. And so the consequences of this are the endothelial dysfunction and the vascular abnormalities. To make matters worse, also inside the red cell is an enzyme called arginase, which consumes arginine, which is the substrate for nitric oxide synthase to make nitric oxide. So not only are you getting rid of it, you're getting rid of that ability to make it. And we'll talk a little bit more later about other components of the red cell content, which are also play a role in the pathophysiology during hemolysis. It's pretty clear that it is not just the red cell, but that other cellular components in the bloodstream are also very much involved in the vaso-occlusive event. And this slide is just to show you some of the epidemiologic data, looking at patients and their probability of having severe disease. And you can see here that it's been recognized for quite some time now, almost 20 years, that significant low baseline anemia, which really means a high hemolytic rate, which probably means a high nitric oxide consumption rate, is associated with severe disease. But I also want to show you that as your white count goes higher, your probability at all of these cohorts gets higher probability of severe disease. So clearly the white cells are also involved. And so this cartoon shows you the normal white cell, which some are adherent to the vascular endothelium, some are rolling, and there are all sorts of intracellular adhesion molecules involved in normal physiology, but also involved in the pathophysiology of sickle cell disease. In particular, we'll talk about the selectins a little later, and they're not only involved with the white cell endothelial interaction, but also potentially with the red cell, white cell, white cell, white cell, platelet, platelet, and all of the interactions between intercellular interactions. So I have a little movie here. It's, I think a picture is worth 1,000 words, but a video must be worth 1,000,000. So it's quite powerful, actually. So this is a mouse who's had sickle trait, been engineered to have sickle trait, who's has his cremaster muscle pulled over a light microscope. And you can see in the background the red cells are flying by. You can't even see them. But the white cells are rolling along. Some are adherent, but they're doing their job. And now you have a sickle-engineered mouse, SS mouse in this case, who has also been induced to have a crisis with TNF. And in the stop frame, you can see the white cells are now adherent. And you can appreciate, although there's no stoppage of blood flow, shortly here you'll see there's quite a slowing. And just that slowing compared to the cells you can't see is enough to decrease the amount of oxygen delivery downstream. So it really sort of gives you an idea of the multicellular and plasma-related gamish and endothelial dysfunction involved in this. And then finally, the only other cellular component is the platelet. And of course, it's involved too. It can't be left out. And so this cartoon shows you a platelet in orange with some of the methods and how a platelet becomes activated. One of them is an autocrine reaction from the release of ADP from dense granules. And this ADP, in again autocrine fashion, binds to the ADP receptors, P2Y12 or P2Y1, to activate that platelet. And so patients with sickle cell disease, because there's hemolysis, and hemolysis also leads to the release of ADP, which is an abundant intraerythrocyte entity, causes this platelets to become even hyperactivated during a vaso-occlusive crisis, when in fact there's usually an increased hemolytic rate. And so maybe the platelets could be a target also. So I hope I've made the point that there's a multicellular and endothelial pathophysiology. The endothelium is dysfunctional. The red cells bind, the sickle red cells bind this endothelium more easily. The white cells are covered in all sorts of Velcro to attach to that, and they're super activated too. And in sickle cell patients, there's more of them in general. The reticulocytes are high because of the hemolytic anemia. They're also stickier than the average red cell. Platelets are activated. Nitric oxide is consumed, which causes some vasoconstriction, which leads to increased red cell transit time, more likely to meet that delay time threshold to lead to vaso-occlusion. And then also in patients, if you happen to do a D-dimer on patients who come in with vaso-occlusive crisis, there's clear evidence that there's also thrombin generation. To make matters worse, there's also probably activation of the coagulation cascade. And the final pathophysiology, you see it's gotten pretty complicated these days. And Charles is going to talk to you a little bit more about this later, but just to introduce the idea of oxidative stress in sickle cell disease. So here's our, not throwing up now red cell, but hemolyzing red cell, which releases hemoglobin, the iron from the heme, and heme itself, all of which contribute to the production of reactive oxygen species and oxidative stress within the red cell. The second part of this is that these reactive oxidation species can directly activate all of those cellular components I've already mentioned, including the endothelium, which can then contribute to the pathophysiology. These increased white cells, particularly the neutrophils, can result in more reactive oxygen species being produced by their NADPH oxidase. And then there's this reperfusion injury that can happen once there's this inflammatory milieu, as potentially there's some resolution of the vaso-occlusion. So the point here is there's a huge amount of oxidative stress, and maybe this is also a potential therapeutic target. So in summary, we have the vicious circle of sickle cell disease. You have red cell sickling leading to vaso-occlusion, regional hypoxia, regional acidosis. Both of these promote polymerization. As the cell gets older, it gets more dehydrated. This also promotes polymerization, more sickling, and vaso-occlusion. Make matters worse, hopefully, you end up with some hemolysis. This leads to oxidative stress. There's activation of the platelets in the white cells, nitric oxide consumption with endothelial activation, more inflammation, and then at the very end, reperfusion injury and a bonus inflammation at the very end. So one of the exciting things, as I mentioned, is the changing landscape, particularly in the US, which tends to also trickle down to other countries, these changing regulatory landscape. And as a pediatrician, in particular, there were two acts of Congress, the Pediatric Research Equity Act and the Best Pharmaceuticals for Children Act, which really were an attempt to try and increase the clinical trials done in children, and that includes those orphan diseases. Orphan diseases were also given their due in Congress to try to spur on research into these diseases, and by definition, an orphan disease in the United States is anyone with less than 250,000 patients, and as we heard from Kathy earlier, we estimate they're around 100,000. So it's an orphan disease in the US, but certainly not globally, as I think you've heard today, so it's an attractive target for many pharmaceutical companies. So let's now talk about some of the pathophysiologically based therapies. I can't possibly talk about them all, but I've just selected four sort of major groups here. And first we'll talk about the manipulation of oxygen binding. So most of you are familiar with the hemoglobin dissociation curve, the sigmoidal shape of the normal hemoglobin A curve. And there's a clinically available test, the P50, which describes the affinity for hemoglobin at any given oxygen level. And as the P50 number goes down, the P of the oxygen affinity goes up. So as the curve shifts to the left, the oxygen affinity goes up. As it shifts to the right, the oxygen affinity goes down. And just for an example, normal hemoglobin is around 25 to 27. Fetal hemoglobin is a relatively high affinity hemoglobin as it tries to take the oxygen off the placenta. And whereas hemoglobin S is actually a relatively low affinity hemoglobin. So our friends in the back here from GBT have come up with a rationally designed small molecule. This is a once daily oral medication. It binds to alpha globin very selectively. And what it does is it causes the sickle hemoglobin molecule to be stabilized in the oxygen-bound formation. In other words, the oxygen affinity is increased, and so the sickle hemoglobin molecule holds on to oxygen a little more tightly. And in murine models of sickle cell disease, it reduced sickling, it reduced hemolysis, and all the consequences downstream of hemolysis, which was quite promising initially. And in some early human trials, you can see here's the oxygen dissociation curve, its classic sigmoidal shape. The placebo here is here in red, and with increasing doses in a dose-dependent manner, they could shift the oxygen dissociation curve to the left in a proof of principle. In a subsequent study, they showed that adults taking the medication could have decreased evidence, biochemical evidence of hemolysis with decreasing total bilirubin or unconjugated bilirubin and decreasing LDH, although maybe a bit of a runoff effect there at the end. And this led to a phase 2 trial, which has now been completed. This was a randomized placebo-controlled trial of the drug now called voxelotor in a young adult and adult cohort, 62 sites, primarily in North America, looking at all genotypes, so this is really genotype agnostic, and they randomized 274 subjects. And their primary endpoint chosen for this trial was the percentage of subjects who had a rise in their hemoglobin by 1 gram per deciliter, with the idea being that in epidemiologic studies, those patients who have a slightly higher hemoglobin have a better outcome overall, again, by epidemiologic standards. And so this is from the New England Journal paper, which was published not that long ago, showing that the patients who were treated here at the highest dose in blue and the people with placebo here in red. And this is the change from baseline of hemoglobin, and you can see that the majority of the patients had a hemoglobin go up, and 59% of them went up by over a gram. You can see those, as you'd expect, on placebo, some went up, some went down. If you look at this in a more longitudinal fashion, for the least square means of change of hemoglobin from baseline, those who received the drug at the highest dose level were on average a little higher than 1 gram per deciliter, whereas those who got placebo didn't go up as you might expect. Unfortunately, though, one of the disappointments was placebo compared to the highest dose of the medication. There was a directionally favorable reduction in vaso-occlusive painful events, but it was not statistically significant and does leave some open questions about this medication. However, this was promising enough that Global Blood had an IPO that raised $150 million. So I'm just bringing in some of the financials here to let you know that there's a lot of investment going on in sickle cell disease, which is sometimes something that patients and families don't really understand. GBT has been very good at standing at the FDA's door because they've managed to get every single designation you could get: breakthrough, fast track, orphan, rare pediatric, and most recently a new drug application, which means the FDA has to choose within the next 6 months whether or not to approve this drug or not. And that's what it did for their stock, which is quite interesting. And as a pediatrician, I'm mostly interested in the Hope Kids 1 and Hope Kids 2 trial, which is they've actually sort of begun to be interested in looking at children again in this, with this medication. So hopefully we'll see that as an option soon. As they've had a proof of principle here that by increasing oxygen affinity, you may have a benefit, others are beginning to pile on to this. And naturally, 2,3-DPG is an entity that when it goes down, it also shifts the oxygen dissociation curve to the left and increases hemoglobin affinity for oxygen. I don't want to make you throw up in your mouth by showing you the glycolytic pathway, but here it is. The red cell relies on glucose for its energy production, and the last stage of this, last step of this is an enzyme pyruvate kinase. And there are now available activators of pyruvate kinase used particularly for pyruvate kinase deficiency and other hemolytic anemia, which when you push more throughput through this glycolytic pathway, you'll end up reducing one of the intermediaries that can be found in the Rappaport-Leuerring shunt, 2,3-DPG. So if you lower 2,3-DPG, you may increase affinity. And so there are several companies who have PK activators who are also probably going to leverage this and start trials in sickle cell. Let's move now to leukocyte and selectin blocking. So there are two major groups who've been looking at this. One, Glycomedics, which has now been associated with Pfizer. They have a small molecule which inhibits all of the selectins, or EP and L selectin. Their approach to the disease was to treat the acute vaso-occlusive event, defined as pain or acute chest syndrome. And they had a phase 2 trial and a phase 3 trial, which I'll briefly mention. And then Celexis, purchased subsequently by Novartis, as I'll show you, had a P-selectin-specific monoclonal antibody, so a sort of a classic biologic type picture, and they took a preventative approach rather than treating the acute vaso-occlusive event, and their phase 2 trial has been completed for some time now. So again, just to show you the idea here, here's the endothelium, the white cells, the sickled red cell, and the platelets. It's hypothesized that P-selectin is involved in all of these intracellular interactions potentially, and that's why it seems that at least this company believes that it's most important. So if we look at the small molecule from the company Glycomedics initially, this is a phase 2 multi-center trial. They had 75 patients randomized at 22 sites across North America. Again, young adults through adulthood, and they selected only sickle cell anemia patients, SS or S beta 0. And the drug is given during acute vaso-occlusive crisis by IV. It's given every 12 hours until the pain resolves. And in the phase 2 trial, this Kaplan-Meier curve shows the probability of vaso-occlusion resolution, and you can see the patients who got drug resolved sooner than the patients who got placebo, and that was statistically significant. Or no, that was not statistically significant, but the trend was in the right direction for this phase 2 trial. What was really quite amazing is that the cumulative IV opioid use was statistically significantly different. You can see those patients who received the medication had almost no opioid use after day 1. Compared to those who received placebo. So it seemed to have some benefit. And this prompted Pfizer to buy them for $340 million. Again, major investments going on in the disease currently. And this led to the phase 3 trial that was run primarily by Pfizer. And this looked at almost 350 randomized subjects at 70 sites initially in North America, but I believe they expanded towards the end. And their primary endpoint came out of the phase 2 trial, which was the time for readiness to discharge, as well as one of the secondary endpoints, the cumulative IV opioid consumption. And so this trial was bare and has been going on for several years and recently completed. And we were hoping to hear at ASH what was going on, but unfortunately it's never good when your trial ends in a press release and not a paper. So just 2 months ago, Pfizer announced that it met none of its primary or secondary endpoints. So we don't really know what's happened with that. We hope to hear more about it at ASH, but this was a great disappointment after the initial favorable phase 2 looking data. And there went their stock price of glycomimetics. I called the person in charge the day after to commiserate, and he no longer works there. It was a frightening economic lesson. So this is the humanized monoclonal antibody initially developed by Silexis. There's the, there's the murine business end of the immunoglobulin molecule, which is specific for P-selectin, bound to a human heavy chain. And this, as I mentioned, is like a biologic. It's given at least every 2 weeks as a loading dose and then monthly. And in their phase 2 trial called SUSTAIN, they randomized nearly 200 subjects at 60 sites, including Jamaica. And they were, these were generally young adults and adults. Again, this would be a relatively genotype agnostic type approach, and so all genotypes were accepted in this trial. The drug was renamed crizolizumab, and as I mentioned, it's given on a monthly basis. And before this trial was actually presented, Novartis bought them for $665 million. Getting a trend here? So shortly thereafter, 2 or 3 weeks after at ASH, they showed their results, which showed that compared to placebo, who were having a median of 3 crises per year, that those in the high dose crizolizumab had about half, 1.6 annual crises. So not a cure, but about a half reduction of vaso-occlusive pain. And these are kind of complicated Kaplan-Meier curves, but this is the time to first crisis on the left and the time to second crisis on the right. And you can see those at placebo were quite quick to get to their crisis. Those in the high dose were statistically significantly slower. And so it increased the time to first and second painful crisis. So there are now some trials that they are busy standing at the FDA door too, also hoping for approval based on that phase 2 data. I don't know if the FDA will be chastened by the results of the rivipansel reset trial, but we'll see. But they've planned a number of follow-on trials, and this one is the first in kids. It'll be a phase 2 trial of about 100 subjects across the globe. Again, only pediatrics, but again, all genotypes. And this is actually already open. It's in stops and starts at the moment. They also have, quite interestingly, have 2 clinical trials which are now open also, or one is open, one is about to open. One is called Steadfast, and it's interesting because it looks at sickle cell nephropathy, something that has not been really looked at closely in multi-center clinical trials. And the other is priapism, also another complication of sickle cell disease, which is somewhat forgotten. And so these are sort of exciting in that they're looking at some of these sort of unmet need complications in sickle cell. So this slide was supposed to be here. So now we'll look at platelet inhibition. I'll go back to the slide. So there are several known drugs which interfere with the ADP receptor, which is activated. Oh boy, I think I did something. I held it too long. So there are several drugs which inhibit the P2Y12 ADP receptor on platelets. And one's called ticagrelor and one called prasugrel. And both of these, prasugrel's had a completed clinical trial, and ticagrelor has one that's underway. So Eli Lilly owns prasugrel and has clinical indications already in coronary artery disease and percutaneous stents. And the phase 3 trial has been completed. And AstraZeneca is working on, they finished a phase 2 trial of ticagrelor, and a phase 3 trial is almost over, and there's another phase 3 trial coming predominantly in Europe. So this, just to cut to the chase, the DOVE trial of prasugrel inhibition showed some directional benefit in terms of the rate of vaso-occlusive crises. You can see here that those on placebo had 2.7 per year, whereas those on the drug had about 2.3. So not a statistically significant reduction, although potentially some hope in this pathophysiologic mechanism. This curve shows the mean number of vaso-occlusive crises on the placebo arm versus the prasugrel arm. You can see they're beginning to diverge, but it was not statistically significant. But again, somewhat hopeful for at least the pathophysiology. And so one of the things that was a bit disappointing being involved in this trial was that it turns out that we didn't inhibit the platelets nearly as much as we had hoped. Most people who receive this drug for other indications have nearly 100% inhibition. Their platelets don't work. But we were looking at a much lower level. Our goal was actually a 30 to 60% inhibition because they didn't want anyone on the study to have any bleeding. So this somewhat complicated slide shows here on the x-axis PRU units. These are platelet reactive units. And the lower the number, the higher the inhibition. So the more inhibited to the left. Those columns which are filled in were those at baseline, and those open columns were the ones that are grayed out here were on fully titrated dose. You can see there's a huge overlap that many patients who at baseline were more inhibited than some people at full titrated dose. So it seems as though they probably weren't getting as much of the drug as they could, and maybe if that had been optimized, maybe we would have seen more benefit. And this is just another way of looking at that. This is the number of patients on the y-axis, and the amount of inhibition here now makes more sense. To the right is higher inhibition. The goal range was here in this sort of red box. And you can see the filled columns, this was at baseline, and you can see even on fully titrated dose, some people had almost no inhibition at all. So I think there was a bit of a design flaw here in this trial, and why other companies who make PDE12 inhibitors, such as AstraZeneca, are moving ahead with their trials. But you can bet that there's going to be a lot more emphasis on making sure there's adequate inhibition. And so the SCiF trial is looking at children with SS or S beta 0, 182 patients at 87 sites. This is very much a global trial with the Middle East, Sub-Saharan Africa, Europe, and North America all being involved in that trial. We don't have any data for that yet. This is just to show you that they were forced to do a much higher level of inhibition, really the goal of 50% inhibition at a minimum. And then finally, in the last 3 minutes, I'll talk here about the manipulation of the nitric oxide pathway. Russell already set me up with the NO alter. And so there's this idea, if you have a low nitric oxide state, how can we increase the amount of nitric oxide that you have in your body? And inhaled nitric oxide is something that's already used in ICUs, particularly NICUs, for pulmonary hypertension, where the vascular smooth muscle is too tight in the lungs. And so the idea is maybe you can inhale the nitric oxide and overcome this hemoglobin sink. And so at our institution very early on, this doesn't look like a very comfortable setup, but if you came into the ER with acute vaso-occlusive pain, you would receive inhaled nitric oxide. And you can see here that there was a reduction in the amount of cumulative narcotic in those who received inhaled nitric oxide, the dark-filled bars, compared to the light-filled bars, although there's quite a lot of overlap there. But this led to a prospective multi-center trial, a double-blind randomized trial in 11 centers in the U.S. Last decade, where they received 72 hours of inhaled nitric oxide. There were 150 participants, and they were looking at a variety of endpoints, including pain relief and the amount of opioid. But unfortunately, even though they completed the trial, you can see these lines are completely overlapping. Those who got inhaled nitric oxide versus placebo, there was no benefit. And so this was abandoned as a method of increasing nitric oxide. There are people who have looked at increasing the amount of arginine in the body. You can do that orally, and there's some ongoing trials looking at IV arginine to try and induce the amount, systemically, the amount of nitric oxide you can make, and those trials are underway. But I just wanted to mention another approach to trying to manipulate the NO pathway. It turns out that nitric oxide has its effect by binding through its receptor, soluble guanylate cyclase, and that converts GTP to cyclic GMP intracellularly, which then has all the downstream consequences. So this is sort of a pathway that we don't have enough nitric oxide to deal with. And so this cartoon just shows you the same thing, that in healthy function you have enough nitric oxide, you make enough cyclic GMP that you have normal physiology of your vascular endothelium. But in sickle cell, where you have a reduced nitric oxide state, you don't make enough cyclic GMP, and then you can have vasoconstriction, you can have endothelial dysfunction, and the company who made this slide looks like a whole bunch of other things. It's also responsible for world wars and other things. But if you try to stimulate, if you can cause the soluble guanylate cyclase to have increased activity by giving it a small molecule and increase cyclic GMP, it doesn't matter how much nitric oxide you have, you've sort of gone further downstream to try and increase this production. And so one company, Cyclerion, has one of these activator medications, and they're currently in the middle of a trial of young adults and adults in all genotypes, and there are sites mostly in the US, but this is becoming a global study as well, so we'll see how that looks further downstream. And then the last thing is just to say that this cartoon, so here again you have nitric oxide, it works on soluble guanylate cyclase to convert GTP to GMP. I've already shown you that. But it turns out the amount of GMP, which has all of its downstream benefits, is also, the amount of that is regulated by its hydrolysis and degradation by phosphodiesterases, in particular phosphodiesterase 9. And there are other phosphodiesterases in the body. PDE9 inhibitor is Sildenafil, which is used for erectile dysfunction. But these are now being investigated in sickle cell disease, because if you can decrease the loss of cyclic GMP, just like how this one would increase its production, maybe this would have downstream benefit. And in mouse models, by increasing cyclic GMP with these drugs, as you can see here in erythroid cells in vitro, that you could increase the amount of cyclic GMP with the drug here in green, that you could decrease sickling in the Berkeley mouse model, a similar amount that hydroxyurea would, You could reduce leukocytosis to a similar degree that hydroxyurea would, and you could reduce an in vitro chamber analysis of vasoocclusion similar to hydroxyurea, and there may actually be even some additive or synergistic benefit. And so, as I mentioned, one company, Cyclerion, has this soluble guanylate cyclase activator, and there are at least 3 companies who have phosphodiesterase 9 inhibitors, which are all coming into clinical trial also in this disease. So I hope in the period of time I've given you a little bit of an overview. There's a lot coming, a lot out there. I hope the patients will be involved. I hope you'll be involved in some of these trials, as although Russell gave a pretty good idea that hydroxyurea here is going to be hard to beat, there still is some unmet need, I think. And there's whole other categories of medications which I didn't even get into here: anti-inflammatory, anticoagulant, or antithrombotics, not only scavenging for nitric oxide, but hemoglobin and heme. And then there's this whole field of antioxidants, which Charles is now going to tell us about. And if you're interested, there in the last year, there have been many review articles looking at the whole spectrum here of available therapies or emerging therapies in sickle cell disease. Thank you.
Thank you very much, Dr. Heaney. That was a great examination of the underlying pathobiology of sickle cell disease and rational targets which are currently in clinical trials. I now would like to introduce Dr. Charles Quinn, who has been recently promoted as professor by Dr. Russell Ware, I think. Right? Yeah. That's right. Okay. So we look forward to this examination of glutamine. Thank you.
All right, so experience with L-glutamine, that was the topic I was given. I suppose I could say, I don't have much, thank you. And then we can be on with our day, but I don't think you wanted to hear that. So we'll start out with the simple pathophysiology of sickle cell disease. As you know, it all stems from the sickle mutation shown there on top, with polymerization upon deoxygenation, cyclic reversible process leading to hemolysis and vasoocclusion. So that's all straightforward. We understand that. It's been established for quite some time. Where does L-glutamine fit into that pathway? I don't know. So went and tried to find the pathophysiology of sickle, the graphs that I could find with the most number of arrows crossing over each other, and these are the ones that I came up with. And you can see Heaney and Ware right there, 2015, they had a lot of arrows. And so, as has been shown by the last 2 talks, the pathophysiology downstream is quite complex. And so, where does L-glutamine fit into there? And I'll try to get at that. Let's just start out with some early history. So why are we studying L-glutamine anyway, using it? And so 40 to 50 years PE, pre-Andari, it says way down there. Some of the investigators in the room here were studying urea, cyanate, carbamyl phosphate, and other compounds that were found to have anti-sickling activities. And giving cyanide and urea is probably not too tolerable in the long term. It's been done, of course, but it spurred a great interest in the 70s, especially in looking for non-toxic anti-sickling agents. And this is one of the first articles that looked at L-glutamine. This is a single author publication in Blood in 1975, where Ruman looked at red blood cells under microscope slides, deoxygenated in saline suspension, and added glutamine or some other amino acids to them. And you can see in the top left for you, sickled cells, and then the next 3 squares show photomicrographs with homoserine, glutamine, and asparagine. And that was it. So there was a morphological improvement with incubation at 3.8 millimolar of those amino acids. And so the interesting conclusion in this article is that it might be possible to prevent sickle cell crises by dietary means. And so, of course, that was very, very exciting in 1975, and even today, of course, we'd like that. This is followed about a year later by some research published by McKenzie in 1976. Ruman, he was looking at microscope slides, deoxygenated red cell suspensions, but what about looking at blood flowing in vivo and measuring the rate of sickling that way? And so he invented this interesting apparatus, like something MacGyver or something would create, but blood flowing in tubes and oxygenators. But they could perfuse blood, flowing blood, with these different chemicals and look at their percent inhibition. So you can see on the graph on the right, there's concentration on the bottom of whatever chemical, and then the percent inhibition is on the y-axis. And so testing all these different compounds, one of them was RPMI, the medium RPMI is anti-sickling, probably from calcium chelation, as it turns out. What he found is that in this assay, L-glutamine had no effect on the sickling rate under experimental conditions. And so he thought that maybe it didn't have any effect because it was mostly bound to plasma proteins in his assay because he was using whole blood. Rumen was using saline suspensions of red blood cells. So to come maybe around full circle in 1980, there's a question here, do amino acids reverse the sickling of erythrocytes containing hemoglobin S? I meant to look it up. There's a law, it's an eponymous law that if the title contains a question, the answer is always no. So, especially for news, you know. And so maybe let's see if that law holds here true. And so what they looked at, so the other two studies were looking at sickling, either morphologically in particular. Here they looked at the minimum gelling concentration of hemoglobin S, and also the filterability of deoxygenated red blood cells, SS red blood cells, through filter paper. And really no effect of any of those three amino acids, L-glutamine is the middle one there, on either minimum gelling concentration or the filterability of SS erythrocytes. Now, interestingly, they saw the same thing under the microscope. The cells looked less sickled. They saw, this is what they said, is essentially the same as that observed by rumen. So they concluded that these changes couldn't be regarded as reversal of sickling and maybe have some other index of some other effect on red cells, such as volume homeostasis. And so we've come full circle from maybe we can prevent sickle crises by dietary means to the use of compounds as anti-sickling agents is therefore doubtful from 1975 to 1980. And so that's the early history. And so what is glutamine anyway? And it is, you know, it's part of who we are. It's our makeup. It's one of the most abundant amino acids in the human body. It's an oxidative fuel for rapidly proliferating human tissues like mucosa, hair, that sort of thing. It's involved in nitrogen transport, regulation of acid-base homeostasis, catabolic signaling. You can read all this, gluconeogenic substrates, required for synthesis of other amino acids, proteins, nucleic acids, nucleotides, hexosamines, all that kind of stuff. And you might be glazing over until you get, this final one, that's of interest to hematologists, right? It's also a precursor for the synthesis of glutathione and NADH and arginine, so it has something to do with maintaining the stability or integrity of red cells and maybe vascular tone. So when we're talking about red cells and glutamine, we're just talking about one of the many roles, and maybe even minor in context roles of glutamine in the body. So let's just focus on that last bullet point and the erythrocyte. So here's the erythrocyte. So glutamine is transported in a specific transporter where it can support the synthesis in green on the top of NADPH and glutathione GSH on the bottom. And so the model here is that these molecules can quench or decrease oxidative stress that leads to hemolysis of sickled red cells. All right, but NADPH and GSH, even though they can be formed from glutamine, they can also be formed from other pathways that do not involve glutamine. That's one thing to remember. And so those are those key antioxidants to quench oxidative stress. So a couple of other technical points before we get into some of the human studies is that in 1988, the Tanaka group, which is the group, and the Mihara group that eventually gave rise to all the studies that led to the approval of L-glutamine, or Endari now. Well, they looked at the role of glutamine in sickle erythrocytes. And in 1988, they found that there was a reduced NAD to total NAD ratio, which suggested that there was increased oxidative stress. And so not as much reduced NAD, but the total amount of reduced and oxidized NAD was increased. So there's more NAD, but most of it's oxidized. And then same group, 1997, came back to examine this and found that there was increased glutamine transport into SS red cells. So the red cells from SS patients are taking up glutamine much more quickly than normal controls and high-risk controls. But the intracellular glutamine concentration was normal in those red cells. So they're taking it up fast, but the intracellular glutamine concentration was normal. But what they did find was increased intracellular glutamate, which is downstream, one of the products of glutamine. And glutamate in particular doesn't have any receptor-mediated transport across the red cell membrane, so it's a byproduct of NAD synthesis derived from glutamine. If I can go back, yeah. So you can see glutamate, glutamine gives rise to NADH and produces glutamate as a consequence. And so they theorized then that there's increased NAD turnover in those red cells because they've increased an ongoing oxidative injury, and that resulted in a compensatory increase in glutamine transport to support that synthesis. And so this was really the idea that formed the basis for the studies of L-glutamine in sickle cell anemia. So just wanted to get through that. So what are the human studies in sickle cell anemia? Well, there aren't too many, and there's only 2 controlled trials and only 1 phase 3 trial. I will say that glutamine has been studied in a lot of different populations, pediatric, adult, critical care. It's been used for just about everything that you can think of, sick populations all around the world and it really hasn't found its niche in any of those populations yet. You know, there's a lot of early excitement, and then, you know, even like in the hem-onc world with mucositis, it was tried. Not too particularly beneficial, but maybe some of the BMT colleagues can talk about that or have questions about that. So in 1998, here's our first human study, uncontrolled open-label study, where they gave 30 grams per day of L-glutamine to 7 patients for 4 weeks. I don't know where they came up with those numbers, and that dose was extrapolated from what they gave other people glutamine for in other conditions. And they did find an increase in the NADH, the reduced NADH with glutamine supplementation, and an improved redox potential, but no change in hemoglobin concentration. So you'd think that if you were improving the redox potential and decreasing oxidative stress within the red cell, you might be decreasing hemolysis, and therefore your hemoglobin concentration would come up. But they didn't find it. But, you know, 7 patients treated for 4 weeks. I'm going to skip down to the one below that. That's also by the same group, where they gave it, again, 30 grams per day, but longer, and to more patients, 11 patients. And what they looked at is endothelial adhesion of those red cells of the patients taking glutamine in an ex vivo system, and they showed decreased endothelial adhesion. But again, no change in hemoglobin or reticulocytes. The Williams study, that's from St. Jude, and this was used for a different reason. This is a treatment to improve or decrease resting energy expenditure, and this is what it is used for in other conditions as well. And they did find that if you use a similar dose, but given BID, but if you correct it for body size, this is all about the same kind of dosing. 6% decrease in resting energy expenditure, increase in plasma glutamine, but no change in hemoglobin. So none of these studies show any change in hemoglobin or reticulocytes. And you'll see that's a theme. All right, so what about the controlled trials? Well, there have been 2, and these are the 2 trials that led to the licensure. The first one, again, with the Mihara group. This was published in 2014 in Clinical Pharmacology and Biopharmaceuticals, I think. SS theta 0 patients, 81, so now we're starting to get an appreciable number of patients. Again, 30 grams per day, extrapolated dose, treated for 48 weeks. The primary outcome, the number of painful events through week 48. Look at the withdrawal rates, 49% glutamine, 62% placebo. So there's something about it. Taking that powder, which we'll talk about twice a day, every day, is not palatable to an appreciable number of subjects, so lots of dropout. And indeed, the trial failed on its primary endpoint, but in secondary analysis, you know, slice and dice it, there was a decrease in the number of hospitalizations with L-glutamine at week 24, but not week 48. But because of that, that's what led to the phase 3 trial. But in general, it was well tolerated, except there was 1 death in the L-glutamine arm due to multi-organ failure. But again, no change in hemoglobin or retic counts. So I'll go back and I'll say this was a randomized placebo-controlled trial, just a small trial. And here we go, the phase 3 trial that led to the licensure in combination with the other data. Nihara, 2018, New England Journal. S beta 0 patients, again, greater than 5. 230 patients, so a good population size. The same dose, 0.3 grams per kilo BID, 48 weeks. And so the outcome was composite of sickle cell vaso-occlusive events, and it could be chest syndrome, pain, that sort of thing. And you had to have a certain number of painful events to come in. But again, high dropout rates, 36% glutamine, 24% placebo. Very high dropout rates. But they did show some benefit. And this was published in 2018. The trial completed in 2014. So there were a lower number, median number of crises in the glutamine group, 3 versus 4, min and max, 0 to 15, 0 to 15. Lower median number of hospitalizations for pain, cumulative days in the hospital, time to first crisis, 2 deaths in the L-glutamine arm. But again, no change in hemoglobin or reticulocyte count. So, I mean, what we see, so why is L-glutamine working if you think this is working? Does it really have anything to do with reactive oxygen species and hemolysis? All right, so those are the data that led to its licensure. So maybe not compelling, but at least it seemed reasonably safe, and I think that was part of the calculus that the FDA used, that it's been used for a long time in large amounts, and it seems to be pretty safe, except if you have hepatic or renal failure, which is something to bear in mind. We may talk about that more in a second. But, so the recommended dosing, this is just, it comes in packets, right? So you have to open the packet, pour it on your applesauce or dissolve it in water. It's kind of like extrate in that way. And you have to take it twice a day. And so if you're greater than 65 kilos, you're taking 6 packets a day, 3 sprinkled on your food twice a day. And then what are the side effects? Constipation, nausea, headache, abdominal pain, cough, pain in extremity, that sort of thing. So it's probably reasonably well tolerated, but it is difficult, I think, to tolerate, I think, for patients. So given this limited data, what is the current role for L-glutamine? And I don't have the one true answer, but I think what we've taken on as our policy or our guiding, whatever you want to call it, is that I think the first thing you have to do is do the right thing, the standard of the care for the patient, which is to optimize their hydroxyurea therapy. You don't want to, and once you've optimized that, then you can consider the addition to L-glutamine, the addition of L-glutamine. So this is, I think it was Katerina wrote the dawn of combination chemotherapy. Right, exactly. And so that's where we're, all of these things soon. Our patients are going to be on a number of these agents. We just have to figure out the right combination. But we don't want to reduce, so it's hard enough to take hydroxyurea once a day, every day for the rest of your life. Adding another medicine twice a day that's not as palatable might interrupt or interfere with your adherence to that. So we don't want to risk that. And so you could consider it as primary therapy for the few patients who don't tolerate hydroxyurea. What its role in chronic transfusions is, we don't know. And it's expensive, $3,000 a month or $1,000 a month for children, which is about 20-fold higher than hydroxyurea. So you can see I've given you the data and the potential role, but really there's really more questions, right? So what is the right dose? That dose was chosen from other studies, just extrapolated and ported over and used. So is there another dose? Dose-finding studies actually were never done for L-glutamine in sickle cell disease. Do different patients with different characteristics need a higher or lower dose? Is it tolerable? Can patients actually take it regularly? And Katerina will have an ASH abstract on adherence to L-glutamine in 100 patients. I'll rather than tell them the results, I'll have them come to your abstract. It's not good, but the abstract is good, but the adherence rate is not good. But I won't. It's a fantastic abstract. So probably it's hard to take. And then how do you know your patient is taking it? You don't, really. There's no MCV equivalent like hydroxyurea. What laboratory marker can you follow, like hemoglobin F? Does the patient need more? Does the patient need less? You don't have that. And then how does it work, really, right? It was sold on decreased reactive oxygen species, decreased oxidative stress, but none of the clinical studies showed any changes in retics or hemoglobin concentration, or the few that did measure surrogate markers of hemolysis. Didn't show any change on that either. So the final slide then is that we're going to try to answer some of these studies. And maybe next year, if you have the meeting here, I can actually answer some of those questions, or the year after. So we'll do this glutamine activity in SS disease study, pharmacokinetics and pharmacodynamics. We're going to look at SS and S beta 0 patients and normal controls. We're going to do dose finding. We're going to look at dietary influences. We're going to do some studies of toxicity, what happens to the ammonia concentration, for example, looking at blood and urine, and then trying to get at how does this work. So we'll look at rheology, whole blood viscosity, after cytometry with oxygen scan, measuring reactive oxygen species, and getting at dense cells, hyperchromic cells, and that sort of thing. And study team there is Cincinnati, Alina Saraf, who's one of our current second-year fellows who's leading this project with us. So I've left you with more unanswered questions than answers. So, but that's, I think, the best we can do. So thank you.
So we have a question. Can you just say your name and where you're from? And
thank you. I'm Nancy Renee. I'm a patient advocate from Los Angeles. And a number of people in our community are on the L-glutamine, known as Endari to us. They have very positive results. I know that's just anecdotal evidence and doesn't count for you scientists. But boy, when you have people who have really been in and out of the hospital in their adult life, I'm talking about a patient who's in her early 40s, and now she can start thinking about a future, she can start thinking about a career. Hasn't been in the hospital but once in the last year. This was a person who literally was living in a hospital. So I would encourage you not to give up on it too quickly. I don't know how much of it has to do with placebo effect, but for some of the patients that we know, they're very pleased.
Yeah, no, so I wasn't saying that it doesn't work. I'm saying we don't know how it works, and we don't know the right dose and how to monitor it. That's what, it may have clear beneficial effects, but
yeah,
we don't know what they are. And as you've seen in a lot of these small studies that Matt presented, there was a great effect. Let's do another study that's bigger and confirms things. And when you actually confirm it, you don't actually confirm it.
Well, I have to add, I actually took it myself, with my patients. We had a little Endari party, and it's perfectly palatable. There is nothing wrong with it. I'm Italian. I'm very, bad with food, so very high maintenance. And it really was not a problem. It dissolves very well. It's a very small packet, and I wouldn't really just try to disseminate the idea that it really tastes bad, because it's not true.
Yeah, it doesn't taste like anything.
And then, as you said, I have 115, 20 patients on Endari, and it is true that after 1 year, only about 30% are still on the drug. But I've also asked my adult patients on hydroxyurea after 1 year how many were on the drug, and that was about the same number.
so we have one more question here.
Just wanted to ask you, I think L-glutamine is also available as an OTC.
Right.
Can you comment about that? And for Dr. Weir, could you make mention of the use of hydroxyurea in non-SS patients, for example, SORA?
Right, so it is very expensive, and you can go to GNC and buy a tub of glutamine. So the question is, what's the purity of that? Is it, even with our highly regulated systems, we're getting recalled batches of losartan and ranitidine for impurities and that sort of thing. And I don't know if anybody remembers the tryptophan and the eosinophilic fasciitis issue back in the 70s? No, it's tryptophan. It was L-tryptophan. Yeah, there was a dietary supplement. It's going to be safe, but everybody got eosinophilic fasciitis. And so it's probably safe. It's probably just as good, but I can only say it's probably. And hope that nothing bad happens.
I think that's an answer that needs to be found, because it's $40,000 a year as Endari and $60 to $100 a month as GNC. So.
With regard to hydroxyurea for non-SS, I mentioned that was on the list of important questions to be answered, and it was recognized by the evidence-based panel as a gap in the knowledge and needed to be addressed. We've used it in severe genotypes, so things that are SD, SOR, these would be amenable because they do sickle. I think the big one that's not answered is SC disease, and maybe S beta plus thalassemia. Those have higher hemoglobins. There might be some concern about that. We had put in a very large grant to NIH for studying this in a multi-center trial for SC, and it looks like that will not be going forward. I heard from the NIH yesterday that despite our exceptionally good score, that it will not, I'm looking right at you. I'm looking, as NIH is pushing to cure the disease, they're forgetting to take care of the 30,000 people in the US that have hemoglobin SC disease.
Okay, so we have time for one last question, and I think Srila has grabbed that, and after that, one housekeeping announcement.
Yeah. It's not a question. It's just a follow-up on what Matthew Heaney referred to about manipulating the glycolytic pathway, activating pyruvate kinase. I just want to say that we have started a phase 1 study on dose and safety finding using AG348, the drug that is being used for treating PKD. And so far, 2 patients have completed, and the results are astounding, I have to say. And the third one is currently going on the 3rd dose. It's dose escalation.
They all describe fetal hemoglobin induction, but I have no idea how it does it. I mean, I realize the 2,3-DPG and all that stuff.
These are just only very preliminary, and the first 2, one is actually stabilized on hydroxyurea, and the second one is hydroxyurea naive, and they show quite tremendous response. That's all I can say. It's very early.
So we have one last question from Deepa. And
this is for Charles. It's a comment, not a question. I just want to point out that in the crizanlizumab study, the high dose arm, 24 patients discontinued the study, 98 were enrolled, only 67 completed. So the discontinuation rate in oral therapy being in that ballpark maybe should be compared to other trials. So it doesn't seem, I think I agree there are many problems with not knowing what to monitor, but just to be fair, fair.
I mean, there was 60% dropout in the phase 2, right? 60% dropout.
Yeah, I'm talking about the final study that led to approval.
So with that, I want you to acknowledge these 3 fine speakers. Thank you for a fantastic session.